Well, good afternoon, everyone. I would like to begin by thanking the organizers for inviting me. And, well, I'll pass the agenda because I haven't enough time. Sorry. Well, the aim of my intervention is to explain you our healthcare system in Spain and the key role family and community nurses have gained over the years. As you may know, our national health system is a beverage type funded through taxation and with universal access coverage. And, well, we have one single national health services, but competencies are transferred to the different 17 autonomous communities. So the country is divided into health areas, which is the fundamental structure for responsible for managing health centers, to managing the health services and implementing health programs. At least the health area must have at least one referral hospital and several basic health zones. The basic health zone it has one main health center and several basic health units, which are smaller, when geographical distance makes access difficult, mostly in rural areas. And there is when the primary care team operates. It's a multidisciplinary team working collaboratively to care for the population living in this basic health zone. So I currently work at Santa Maria Health Center, which is a rural primary care in Mallorca. We provide care for over 17,000 inhabitants living in Santa Maria, Bunyola, and Santa Eugenia. And, well, our primary care team is composed by 13 nurses, 2 of them pediatric, 10 doctors, 2 pediatricians, 1 complex case management nurse, a midwife also, 2 healthcare assistants, and 7 administrative staff. And the team is coordinated, but it's also distributed between the main health center and these small local units in Bunyola, in Palmanyola, and Santa Eugenia. So every patient has a doctor and a nurse assigned, and this is the patient micro team, we call it micro team. He can request an appointment with any of us, with the doctor or with the nurse, depends on the interest of the patient. And the goal of the micro team is to improve continuity of care, to enhance communication, and to increase efficiency by ensuring patients are always, or we try at least, but always see the same providers. Coordination between micro team is essential, especially in complex chronic patients. If we talk about nursing academic evolution, well, before 2008, you could, if you wanted to be a nurse, you could study a 3-year university diploma. But since the Bologna process now is a 4-year university degree, 240 credits, and then when you finish, you can access to a master and then later to a doctorate. But in Spain, some healthcare professions have another pathway, have specialties. When you finish, when you're a nurse, you can pass a national exam and you can choose any of these specialties. Of course, family and community nurse, mental health, occupational also, pediatric, geriatric, and a midwife, of course. The specialty training system is based on a 2-year residency with a very practical approach. While you are acquiring theoretical knowledge, you are also beside your tutor in a real health center with real patients, training your skills as a family and community nurse. The specialties were created in 2005, but it wasn't until 2010 when the government created the specialty training programs. Since that year, the number of residents that started their residency has been increased every year. In this same year, in 2026, more than 950 nurses have started their residency, their family and community nurse residency. But besides, an exceptional pathway was established for nurses that were working for 4 years or more in primary care field. In 2022, we did a national exam, and those who passed, we obtained the specified qualification. So nowadays, we are more than 17 family and community nurses specialists in Spain. However, the implementation of the specialty is uneven across autonomous communities regarding creation of specific jobs or professional recognition. Regarding advanced practice, although many nurses work developing advanced practice competencies, this role is not yet officially recognized or regulated in Spain. Well, as I told you before, in my opinion, we family and community nurses are playing a key role nowadays in primary healthcare model, but at the beginning we didn't. In the middle 80s, when the primary care model expanded and nurses joined the family and community, the primary care team, the model was more doctor-centered, more reactive than it is today, and our role, nurses' role, was more technical, with less autonomy, and with more limited competencies. But a few decades later, there appeared many challenges, with population getting older, like in all Europe, I suppose. Chronic diseases prevalence increased. Also, doctors' agenda were overloaded, and the initial intention of implementing community health interventions had not been achieved. So, to face these challenges, the healthcare model evolved, and concerning nurses, they put more nurses in the field, and nowadays the approach is more multidisciplinary and preventive, and we work with more autonomy, leading chronicity and community health mostly. But it seems it's not enough. I'm not happy to say that our family and community nurse ratio is 0.58 family and community nurses per 1,000 inhabitants. And the National Association of Family and Community Nurses in Spain estimates we need to be from 1 to 1.2 per 1,000 inhabitants, so we need to increase, we need to double. So we have a long way to run. So now I would like to talk about our current service portfolio. Nowadays, we lead community health interventions, as I mentioned. We work collaboratively with local organizations, such as schools and high schools, city councils, elderly associations. We implement vaccination and screening programs. We are the main responsible role organizing group education, such as smoking cessation, fall prevention in frail patients, active aging in pre-diabetes patients, and caregiver support groups, etc. We also lead chronic disease management through our assessment and care plan. We promote the patient's lifestyle changes and self-management. We are also authorized to request and perform autonomously several complementary tests like blood tests, spirometry, ABI, like KBPM, ECG. The patient doesn't need to go to the doctor first. So if we think it's time to do it, well, we request it and we do it. There's no problem at all. I think this way we help the system to be more efficient and responsive. We have also the continuity of care program, essential in chronic patients when they are discharged from hospital. By simply clicking a link from our medical record, we can have access to the hospital record, and it allows us to provide better care because we can see the patient's progress during hospitalization, and we ensure coordination between different levels of care. And, well, this is what I love most. We are the main care reference from frail patients who cannot come to the health center. We have the home care program, and we try to do what we would do if the patient would come to the health center, but at home. Of course, family support here is very important. And we do our nurse assessment and care plan. We support the caregiver. We help him to organize all the care plan. We monitor chronic conditions, searching for detect early decompensation. We, of course, take care of pressure wounds. We coordinate with other professionals like social workers, physiotherapists, of course, our micro-team doctor. And we even do palliative care at home The micro team is responsible for doing that, but in some complex cases, we can refer the patient to the home palliative care team, which is a specialized team, but we don't leave the scenario. We keep beside the patient, and we try to coordinate with the palliative care team. That's very easy for us because we share the same software. So, well, we know it's easier when we share softwares. And the most recent competence we've assumed is the assessment of minor acute health problems, like upper respiratory tract infections, or diarrhea, or insomnia, or anxiety, or airway plugs, urinary infection in women, and this kind of issues. And we autonomously assess it, and of course, if we think the patient deserves, well, not deserves, sorry. If the patient needs to refer them to the doctor, we of course do it. Since 2018, in 2018, the Ministry of Health approved nurse prescribing guidelines. We currently have 9, but again, it depends on every autonomous community to develop their own protocols. In our case, in Balearic Island, we only have approved 2 of the 9, but we are expecting to get the 4 of the 9 protocols more, so we could prescribe more medications. Well, I wouldn't like to finish without mentioning management or nurse care is one of our competence. Not directly has an impact on the patient, but yes, indirectly. And of course, research and teaching undergraduate and postgraduate is still one of our competencies, and I think it must be. And I think I'm finished. I know I've left many things unsaid, but I haven't enough time. If you have then any question, yeah, that's true. Well, I think it's on to Martin.
Thanks. Yesterday evening, Marta told me that she will need 16 or 15 minutes. I think you're very fast. But I have prepared elevator pitch for the last, oh, thank you, Robert, for the additional time. Let's have a look where we are. I'm from the district Meißen. You can see the red point, and yeah, for the marketing part of the elevator pitch, you can see the picture below. It's the city of Meißen. It's always sunny. We have so much wine. It's, yeah. If you like to visit, just do it. It's only 200 kilometers away from here. And although I live there with my 5 children in the district, we have a decreasing inhabitants. I do what I can. Yeah, and the lack of the youngest, and we have an aging population with a need of care. It's increasing about the last years, and at Meißen, as you can see below, we are the second at the federal stage. So there are problems. On the right, we have problems in Germany with multimorbidity, especially in Saxony, and maybe you know this chart. It's a heat map for the avoidable death due to a lack of prevention and, yeah, due to prevention. And Germany is red. So we have problems, but we are in Germany, and we think we have good stakeholders. We know that fact. The general medical doctors are decreasing, and nearly 30% are over than 60 years. So for the future, we have problems. The same in ambulatory caring services. There are 105 companies in the district of Meißen, but we have problems in rural areas. And no, we don't have a lack of hospitals in Germany. We have too many hospitals. That's a problem. And the most problem is that we employed so many nurses at the hospital, so many nurses we need in the primary care sector. So, as an appeal for the health insurance providers, we speak about financing, just avoid costs for disease treatment. For example, I'm a nursing director, I calculate always smart. We'd use 6 knee total anaesthesias per year and finance 1 community health nurse. For example, it's easy. To politics and government, look abroad and just make a law. I know you do that, it needs some time, but please do it smart and do it applicable for us. To the healthcare providers, for example, to hospitals, let's start. Katharina Janus told us, let's start, so let's start. Meissen is divided in 5 planning regions, so let's start with 5 CHN as a powerful team, I think, and maybe we can assist with experienced academic, if we have, or non-academic nurses, for example, with specialization of pain nursing, heart nursing, dementia care nursing, diabetes care nursing, and so on. To the public administration is my appeal. I think it's easy, connect each other, that's your part, and you're independent enough to do that. And I think this is important to the nursing staff. Here are so many nurses, I think, and community health nurses. Stay optimistic, stay persistent, ambitious. It's a long way, yeah, we have to run a long way. I can run long ways fast. Let's do it together, yeah. And last but not least, let's have a look abroad. I think it's always a good decision. Yeah, thank you.